Meckel-Gruber syndrome, a lethal ciliopathy with genetic and sonographic implications, by Mina, Marie, Moria, and Eric.
First described in the literature by Johann Friedrich Meckel in 1822, Meckel-Gruber syndrome is a lethal autosomal recessive congenital malformation that typically presents clinically as a triad of occipital encephalocele, large polycystic kidneys, and post-axial polydactyly. It is part of a larger group of syndromes caused by ciliopathies, mutations in genes that encode structural or functional aspects of cilia and flagella. Regarding Meckel-Gruber syndrome in particular, mutations of 14 different genes, most commonly TMEM67 on chromosome 8, are currently identified as causing malformation and dysfunction of the primary cilium. These organelles, located on the apical surface of most epithelial cells, are responsible for receiving, relaying, and regulating chemical and mechanical signals. These mechanisms are essential for maintaining cellular function and allowing organogenesis during embryonic development. While MKS has been genetically mapped to the loci of 6 different chromosomes, genetic mapping is considered incomplete due to its vast genetic heterogeneity.
The worldwide incidence of MKS ranges from 1 in 13,000 to every 1 in 140,000 live births, with significant regional variations. In Europe, Belgium reports MKS in 1 in every 3,409 births, Finland 1 in 9,000, and Great Britain 1 in every 140,000. Due to its distinct anomalies detectable in utero, most cases are accounted for, although some may go unaccounted due to abnormal presentations in utero, stillbirth without diagnosis, or possibly termination. Higher incidence rates are observed in endogenous populations, which are those who marry and reproduce within the same community. Their rates increase to 1 in 9,000 births. An increase is also seen in consanguineous populations, which are those who descend from the same ancestors. Their rates are 1 in 3,530 births. The graph on the right demonstrates MKS rates per 100,000 live births, showing an increased rate in Finland in endogenous populations compared to the worldwide max. And another significant increase is seen in consanguineous and Belgian populations.
Meckel-Gruber syndrome is a lethal autosomal recessive disorder, classified as a ciliopathy, meaning it arises from defects in the primary cilium, which is a crucial organelle for cellular signaling and embryonic development. Mutations are found in at least 14 genes, including MKS1, TMEM67, and CEP29, which disrupt key pathways like Hedgehog and WNT, which are crucial signaling mechanisms that regulate embryonic development, cell differentiation, and organ formation. These lead to severe abnormalities such as neural tube defects, cystic kidney disease, and polydactyly. MKS follows an autosomal recessive inheritance pattern, meaning both parents must carry a defective gene, with a 25% chance of reoccurrence in future pregnancies. Despite advances in genetic research, only 50 to 60% of cases can currently be explained by known mutations, suggesting that additional genetic factors remain unidentified. Understanding MKS is crucial for improving early diagnosis and genetic counseling.
Meckel-Gruber syndrome can be diagnosed by looking at patient history, genetic testing, and diagnostic imaging. Consanguineous relations and history of MKS are both associated with a greater likelihood of MKS. Prenatal ultrasound is the primary used method to diagnose MKS. The presence of polycystic dysplasia of the kidneys, occipital encephaloceles, and polydactyly are the triad appearance used to diagnose MKS. Later in pregnancy, there is usually severe oligohydramnios and ultrasound has poor visualization, then MRI can play a key role. Genetic testing can be done via chorionic villus sampling or amniocentesis. Whole genome testing can be done if there's limited knowledge of what gene is mutated, and if more information is known, then multi-gene panels can be performed by obtaining a few characteristic genes to single out MKS. Many genes can be mutated with MKS, most common being TMEM67 and the next most common being the MKS1.
The first signs of Meckel-Gruber syndrome can be detected on prenatal ultrasound at around 10 to 14 weeks, when the hallmark triad of anomalies can be visualized. As alluded to previously, these include polycystic dysplastic kidneys, an occipital encephalocele, and polydactyly. However, a wide variety of fetal anomalies, which include facial abnormalities, CNS abnormalities, cardiac septal defects, and gastrointestinal anomalies, have shown varying levels of association with MKS. In 97.7% of suspected cases, destruction of renal parenchyma due to microscopic cysts causes enlargement of the fetal kidneys up to 20 times their normal size, with subsequent enlargement of the fetal abdomen. Sonographic signs include abnormally heterogeneous corticomedullary differentiation with increased cortical echogenicity, decreased medullary echogenicity, and numerous subcentimeter cysts. The associated renal dysfunction can also cause non-visualization of the fetal bladder and subsequent oligohydramnios or anhydramnios in the second trimester when urine production replaces extracellular diffusion in the production of amniotic fluid. This can increase the difficulty of subsequent assessments of the fetus and may require switching to alternative imaging modalities such as MRI if sonographic findings are inconclusive. The second most commonly visualized anomaly seen in 87.3% of cases is postaxial polydactyly. Postaxial meaning that it can occur on the ulnar aspect of the hands or the fibular aspect of the feet. Other limb-related anomalies associated with MKS include clubbing of the hands as well as bowing or shortening of the limbs. The third most common anomaly seen in 83.8% of cases is the presence of an occipital encephalocele. Best visualized on ultrasound in axial views of the fetal head, it presents as a herniation of the brain parenchyma and CSF into a pouch of exposed meninges. If the meninges remain intact, AFP levels may present as normal with correlated testing. However, if disrupted, subsequent increases in AFP levels can be expected. Visualization of an occipital encephalocele can also be accompanied by various CNS anomalies which include, but are not limited to, ventriculomegaly, agenesis of the corpus callosum, craniorachischisis, Dandy-Walker malformations, and Arnold-Chiari malformations. While visualization of the triad of anomalies is considered diagnostic for Meckel's Gruber, it shares common appearances with other ciliopathy-induced syndromes, such as Joubert syndrome, Carpenter-Hunter syndrome, and Bardet-Biedl syndrome. Therefore, a definitive diagnosis typically requires clinical correlation through genetic testing. The prevalence of the triad of anomalies also varies across studies. The values described in this presentation were compiled from a large-scale population-based study with a predominantly European study group. However, other completed studies have shown different incidence rates for the anomalies seen in the classic triad, which may indicate differences across distinct ethnic groups.
Differential diagnosis. The most common differential is trisomy 13. Similarities include enlarged kidneys, occipital encephaloceles, and oligohydramnios. The differences between the two come from sonographic findings. For trisomy 13, there is a strong association with CNS abnormalities, particularly holoprosencephaly, which would not be characteristically seen with MKS. Additionally, previous pregnancies with MKS are associated with recurrence of MKS. A chromosomal analysis can be used to differentiate between trisomy 13 and MKS. Another differential, Joubert syndrome, shares similar alleles with MKS, which can make it challenging to diagnose with chromosomal analysis. The key findings that can help distinguish Joubert syndrome is midbrain and hindbrain abnormalities and the key molar tooth sign being seen. Other differentials for MKS include trisomy 18, Bardet-Biedl syndrome, and Smith-Lemli-Opitz syndrome, which can also share similar alleles with MKS. However, with the use of chromosomal analysis, they can be distinguished from MKS. The following images show the sonographic appearance of trisomy 13 and Joubert syndrome. With trisomy 13, there's holoprosencephaly as seen on the left. On the right, there's the molar tooth sign seen with Joubert syndrome. This shows the fourth ventricle communicating with the cisterna magna, with an asterisk over the abnormality. These findings would not commonly be seen with MKS.
As previously mentioned, MKS is lethal and is characterized by its classic triad of complications: cystic dysplasia, polydactylia, and central nervous system malformations such as occipital encephaloceles. Hepatic fibrosis, although not part of the classic triad, is a common complication that is seen in approximately 65.5% of cases. Renal cystic dysplasia is the most defining complication of MKS. It will result in enlarged kidneys, enlarged abdomen, decreased urine output, ultimately leading to renal failure. A decrease in fluid levels is a secondary complication. Oligohydramnios or anhydramnios can lead to a bad environment for development, resulting in compression-related deformities such as facial anomalies, musculoskeletal malformations, and pulmonary hypoplasia. Pulmonary hypoplasia develops as the fetus does not have any fluid to breathe in and expand its alveoli for proper development. This is the main cause of death in MKS. Hepatic complications are typically fibrosis and ductal plate malformations, which lead to progressive dilatation of the biliary structures and increased connective tissue in the portal tract. Additional MKS complications include short and long bones, genital abnormalities, cleft lip and palate, heart defects like ventricle and atrial septal defects, and co-articulation. Central nervous system anomalies beyond encephalocele include cerebral hypoplasia, Dandy-Walker anomaly, agenesis of the corpus callosum, and holoprosencephaly. The presence of at least two primary triad features raises high complication risks, with severe cases leading to intrauterine demise due to renal failure, liver dysfunction, and pulmonary hypoplasia.
MKS has an extremely poor prognosis, as it is lethal in utero or shortly after birth, with most affected newborns surviving only a few hours or days. The primary cause of death is pulmonary hypoplasia, which results from severe oligohydramnios caused by bilateral cystic renal dysplasia, a hallmark feature of MKS. Given the fatal nature of this disease, clinical management focuses on early prenatal diagnosis and genetic counseling. Ultrasound screening, typically performed in the first or early second trimester, can identify large echogenic kidneys, occipital encephaloceles, and postaxial polydactyly, which together strongly suggest the presence of MKS. If diagnosed, parents receive genetic counseling, particularly if there is family history of MKS, since the disorder follows an autosomal recessive inheritance pattern with a 25% reoccurrence risk. Pre-implantation genetic diagnosis, or PGD, and early first trimester screening may be offered to at-risk families to help guide reproductive decisions. In cases where the fetus is carried to term, Palliative care is the primary approach, as there is no cure or treatment to alter the disease course. While genetic research continues to improve prenatal diagnostic methods, no therapeutic interventions currently exist. So warning, this is a graphic image showing Meckel-Gruber syndrome outside of utero. So this is an autopsy image of a fetus retrieved from Corona et al. And this is demonstrating the classic triad of MKS with a distended abdomen. And image B shows the occipital encephalocele. Image C shows the polydactylity, and D shows the bilaterally enlarged kidneys. These images also show the presence of an open neural tube defect, underdeveloped limbs, and most likely two oligohydramnios in the womb, and cyanotic appearance due to the pulmonary hypoplasia.
In conclusion, the key takeaways from our presentation is that Meckel-Gruber syndrome is a rare but lethal autosomal recessive disorder. It is found in 1 in 13,000 and 1 in 140,000 live births. It is also higher in specific populations such as Belgium and Finland. The key sonographic triad is polycystic dysplastic kidneys, occipital encephaloceles, and postaxial polydactylity. For diagnosis and genetic factors, ultrasound is typically performed between 11 to 14 weeks, and it detects the sonographic triad. Oligohydramnios may be present, and it also may limit the visibility, therefore MRI may be required. Genetic testing confirms the diagnosis, and it is performed through amniocentesis and CVS. And over 14 genes are involved in this disorder, and most commonly it will be the TMEM67 and MKS1 genes. For prognosis and management, it is fatal within hours to days due to the renal failure and pulmonary hypoplasia. There is also a 25% reoccurrence risk, therefore genetic counseling is crucial. Currently, there is no curative treatment, so management focuses on early identification, parental support, and palliative care. And ongoing research into ciliopathies may lead to future therapeutic insights. Thank you for listening to our presentation on Meckel-Gruber syndrome.